Sorry about that. So now we're going to start with our segment on research students. So what we will do, we have students that will present their abstract. I believe you all received their abstract on arrival. And so they will have 8 minutes to present their talk. And after that, we'll have about 2 to 3 minutes of questions, and then we'll move to the next students. And after that, we'll have the closing remarks for our half day. So I will let Daniela present our first presenter.
Okay, so our first presenter is medical student Daniel Moses, and he's going to present on neonatal outcomes related to the early discovery of alterations in cardiac function, a 7 to 10 days for the left ventricle analysis. Thank you so much, Daniel.
Oh, I can talk here. Hi, everybody. Excellent. So I'm Daniel. I am a second-year medical student, and I started in a NeoCardioLab this summer. And I'll be presenting my research on neonatal outcomes related to discovery of alterations in cardiac function, a 7 to 10 day 4D left ventricle analysis. I'd like to first start off by acknowledging everybody that was part of this work and the reason that I'm here. Today, first, the NeoCardioLab and my supervisor, Dr. Altit, for accepting me in the lab. It's been a great experience. Project manager, Daniela, for all the work and the training that she's provided me. All my lab members, the co-authors that have given me a lot of feedback, the funding for this project, and also the research bursary that I received. It has been an amazing experience working in the NICU and seeing all the amazing things that they can do for this vulnerable population. And that vulnerable population is the demographic of my research, extremely premature neonates. These are neonates born less than 29 weeks of gestation. There's a high risk of mortality and morbidity, common issues relating to the lungs, including pulmonary hypertension, affecting the heart, the vital organs, and that can lead to mortality. And so treatment is, relates to the reducing the strain on the right ventricle. But a lot of studies in investigating the heart of these neonates also found that the left ventricle, which we know is needed to pump blood through the rest of the body to the vital organs, was also found to be smaller and decreased function. And so could the left ventricle be a predictive factor for some of these complications later on? Well, that would require some extensive characterization and analysis of the left ventricle in these neonates. And that is the objective that I'm presenting here today, which is to characterize the left ventricle structure and function in these neonates in the first week of life, so 7 to 10 days, and then also explore associations with perinatal factors. So the workflow that I'm presenting today, here, is actually just to demonstrate that this is part of a large study called the Nordic PREM study, which looks at cardiac ultrasounds at different time points in the baby's life. And my work really focuses on the first week. So it's a part of this large study. The workflow that I took on this summer, I broke down here, starts off by receiving a list of patients and figuring out which ones received a cardiac ultrasound in the first week. And then taking those hard ultrasounds and analyzing them using a program called TomTech allowed me to take dimensions of the left ventricle. And I did this alongside performing a chart review on the mother and infants to collect clinical and demographic data. And then by having all the measurements on the left ventricle and all these demographic data, I can then perform analysis and put together tables and figures that I'll be presenting today. So let's start with some screenshots from TomTech that I used. So TomTech is a program that allows me to take measurements of the left ventricle. And we see in green, I am able to outline the left ventricle in both the 4-chamber, 2-chamber, and 3-chamber views, providing me with a 3-dimensional contour output of the left ventricle. But what's interesting is that I'm able to do this in both systole and diastole, allowing me to get a 3-dimensional measurement of the left ventricle in a full cardiac cycle. So I don't only get dimensional output, but I also get functional deformation output, such as strain, torsion, and twist. And so of what I'll be presenting today is of the first 40 patients that I collected data on. And here I just want to show that this program allowed me to get an output of the diastolic volume, systolic volume, the left ventricle mass, the length of the ventricle, but also measurements such as strain in both the longitudinal and circumferential direction, twist, and torsion. And like I said, alongside this, I performed a chart review on these infants and their mothers. And what I'm presenting here today is just some of the data that I collected, such as the baseline characteristics like gestational age and birth weight, perinatal and delivery factors like use of antenatal steroids, the respiratory and clinical course, so how many were intubated in the first minutes of life, some morbidities and outcomes. So this is just a kind of an overview of what I've been collecting. And now it was time to try to find some links. And so when I looked at what perinatal factor led to some significant difference in the left ventricle, what was interesting is when I looked at gestational age with this cohort of 40 infants, I was unable to find significant values at this point, significant differences. Same thing with postnatal steroids. But what was interesting is when I stratified the group of 40 into two based on the median birth weight of 932 grams, this is when I start to get significant differences between these two groups in the left ventricle metrics, such as end diastolic volume and stroke volume and length. So the first group, group 1, where birth weight was less than 932 grams, had a smaller stroke volume, smaller end diastolic volume. And in terms of functional metrics, they also had a more negative global longitudinal strain and a higher torsion. And then the comment was brought to my attention in that, well, maybe the group where they are lower birth weight, smaller birth weight, maybe they have a smaller heart because they're smaller babies. And that is a good point. And so in order to understand what's actually happening, is it that the heart is smaller or that the heart is adapting differently? We had to normalize our data to body surface area. So I calculated the body surface area at the time of echo using the Haycock's equation, which is using the weight of the baby and the length of the baby at the time of echo. And I used this value and divided all of our cardiac metrics by the body surface area to normalize it. And what was interesting is we found that all of the dimensional outputs, so end diastolic volume, stroke volume, the mass, what was once significant became insignificant, meaning that it was really just scaling with the body size. But the other metrics, such as strain, torsion, and twist, became highly significant, meaning that the way that the heart was pumping was different. So I summarize these findings here by saying that after normalization to body surface area, these structural differences disappeared, indicating that the chamber to left ventricle size was really just scaling with the body size rather than birth weight itself. However, the functional and deformation findings, strain, torsion, and twist, seemed to be an association with birth weight even after normalizing for body surface area, suggesting potentially an adaptive process. The way that the heart is pumping is different in this low birth weight group. And what I'm presenting here is just one part of all the demographic data that I was showing you before, stratified between the two groups. And I wanted to bring to your attention this part, the respiratory and clinical course, to show that group 1, the ones with a birth weight less than 932 grams, had a longer hospital stay. They were on O2 support for a longer time, were less often on room air at 36 weeks, had more use of postnatal steroids, and were more often intubated in the first 30 minutes of life. So showing that they had a longer hospital stay and a more complex course in the hospital. And so I'm going to summarize my findings here and my conclusions in that group 1, the birth weight less than 932 grams, had a smaller left ventricle. But this significance was actually removed, it disappeared after normalizing for body surface area, indicating a more proportional growth. But metrics such as longitudinal strain and circumferential strain were consistently significant even after normalization. potentially proving some sort of adaptive measure to maintain cardiac output and other measurements. So this group also had a higher torsion and twist even after normalizing for body surface area, suggesting a potential altered mechanics in the way that the heart is pumping to maintain a stroke volume because of the smaller left ventricle. And also what was found in this group is that they have longer hospital stays and a more complex postnatal course. But there's a lot to do. So my future direction here is to complete the full cohort of 138 patients. What I presented today was just the first 40, and that would hopefully increase the statistical power. And then I want to investigate links between these metrics and clinical outcomes. So what I presented before was more the clinical course, showing that it was more complex. But what about the clinical outcomes, such as bronchopulmonary dysplasia, pulmonary hypertension, and mortality? And then this is the question, could we find a marker as a predictive factor for these outcomes, these adverse outcomes in these extremely premature infants? And that we'll see. So like that, I'd like to thank you, and I'm open to any questions.
Thank you so much. 10 minutes on the dot. Okay, so does anyone have any questions?
Yes.
Thank you. Thank you, Daniel, for your excellent presentation. I have a question with regards to the incidence of steroid use and whether you have any data on blood pressure and whether systemic vascular resistance may play a role in the findings and the different groups that you studied.
Blood pressure was documented, but not included in that table in my presentation. Could you just actually further expand on that question so then I could go and take it home and think about it?
You know, like blood pressure is afterload, and afterload can affect function. And I was wondering whether, since steroid use can cause high blood pressure, whether there's a relationship between steroids, high blood pressure, and myocardial performance.
Okay, something I will look into. Thank you.
This is going to be a tough question. I'm sorry.
Excellent.
If you need to adjust for body size, so the first is a comment. So you should probably use height and weight instead of body surface area, because body surface area is something that you don't actually measure. So you have more precise measurements. So if you do a calculation with body surface area, you impose some restriction on your equation, and it's usually not useful. So having a Z-score based on height and weight is probably better than just simply dividing for body surface area. So that's a comment. The question is, if you take a value that is not supposed to change with the size of the baby and you divide by the body surface area, you will create an association by doing this that is not actually there. So you need to be careful. So did you consider this, that dividing by the body surface area was the thing that created your associations previously, and not because you actually observed something that was associated with an outcome?
No, I didn't. But I completely understand your question. But it is not something. It's interesting because I guess I'm dividing a metric of the left ventricle by something completely different, body surface area, and you're saying that because I'm dividing by there, maybe it's just, but if all of the values were divided by that, and no, I have not considered that actually.
So in your analysis, what's going to be difficult, right, is you have to tease out what is the normal variation of all these metrics with the body size of the growth or the maturity of the baby, and then decide what is just a normal thing and the ones that are abnormal and associated with abnormal hemodynamics. And this is going to be a very tough analysis to do. So you have lots of work for you.
Just a counter question to this. Because I divided by body surface area, you're saying I should actually normalize it to length and weight. Would the same thing apply if I normalize it to length and weight? versus the body surface
It could, but it depends on how much you normalize. So something that should not change with the body size, you don't have to normalize. And if you normalize it, then you induce a new association. So you have to know which measure you're going to need to normalize. So
Okay.
you need to know what is normal, and then you need to normalize to what you now know that is normal, which is very difficult in a premature baby.
Okay.
It's
Thank you.
doable. It's just complicated.
I liked it, so don't worry about him.
Thank
Now,
you.
what Fred is saying is that height and weight are measurable, but the surface area is a calculation. There are at least 4 or 5 equations for BSA.
Mhm.
For those for infants and children, it's not the one we typically use. So there's an array of different, variations in BSA calculation because we don't measure it. Okay.
Okay.
So, but I think why use it? Because people have been using BSA forever. But this is his lifetime achievements, fading away from BSA for multiple reasons. One of the examples, my BSA 6 months ago was bigger because I was fatter than today.
Yes.
Okay. So it's a fictive thing. I don't think my skin became much larger in terms of surface, but my weight was heavier, and therefore my BSA was larger. So if you divide today versus 6 months ago, your measurement to my BSA, when I was fat, I had a lower number because the denominator was higher. It doesn't mean that my heart became smaller. I had the same heart, but denominator you used is different. My height will not change within 6 months. My weight will change. So that's this an overall like to explain things why BSA we're trying to shy away from it and go to more measurable data. Now the other issue is when you look at equations using BSA or height or weight, again, it depends how people use those equations, and we have to go with them because this is what is available. But practically speaking, these are two different things, right? BSA could be misleading. BMI.
No, we're going to leave him alone.
Thank you. I appreciate that.
Okay. Okay, thank you so much, Daniel.
Thank you very much.
So next we have Zoe. Zoe was also one of our summer students this year with us at the NeoCardioLab. So she's going to present on perspective for the echocardiographic characterization of the left ventricular function in CDH. Okay, perfect. Can I use person interview? What's that? Can I use person interview? Yeah, of course. One second. Green light. Okay. So you have to move and you have the yes reverse my hand. Okay. Okay. So okay. Inject. Oh. Oh yes.
Okay. Okay, so hi everyone. My name is Zoe and I'm a medical student working with Dr. Antit at the NeoCardioLab. Today I'll be presenting my work, which is part of a larger Nordic CDH project. This study explores how the severity of CDH influences postnatal cardiac recovery during the first weeks of life. So, congenital diaphragmatic hernias occur when the diaphragm fails to develop, and so the opening allows for organs of the abdomen to move into the chest and compress the heart and the lungs. Particularly, the presence of liver herniation is considered as a known marker of severe CDH. So this compression restricts the lungs, leading to pulmonary hypertension and pulmonary hypoplasia. The increased pressure in the chest can also interfere with cardiac development, leading to cardiac hypoplasia, which has been described in both fetal and postnatal life. However, how this impacts actual function hasn't been well established. After birth, these infants undergo surgical repair to close this hole, as well as to reposition the abdominal organs. So despite these advancements in care, CDH continues to carry a high morbidity and mortality, primarily due to the respiratory and cardiovascular complications. So most current medical therapies for CDH focus on treating the pulmonary hypertension, since this is known to cause a lot of poor outcomes, such as the need for ECMO. However, inhaled nitric oxide, a pulmonary vasodilator used for lowering pulmonary pressures, has not been proven to be effective in this patient population. And one of the reasons that has been suggested is because of underlying LV dysfunction, which limits the heart's ability to handle the increased blood flow after birth. So, previous studies using echo have shown that newborns with CDH who have more severe complications have reduced postnatal LV function and size. So despite improvements in neonatal care, we still have limited evidence on how early cardiac dysfunction in CDH relates to long-term outcomes, as well as little understanding of how cardiac adaptation differs by disease severity during the first weeks of life. And so my research project's question is, does the presence of intrathoracic liver herniation, which is a marker of more severe CDH, impact postnatal left ventricular adaptation? So the aim is to characterize early postnatal LV structure and function using 4D echo to assess whether more severe CDH is associated with persistent LV alterations within the first weeks of life. So to do this, patients with prenatal or postnatal diagnosis of CDH were recruited at birth, and we performed serial 4D echo, as well as taking into account clinical characteristics and ventilation parameters. And we did this at 3 distinct time points. So we did it at the first 24 hours of life, day 3 to 5, as well as 2 weeks of life. And using these 4D echo parameters allowed us to evaluate LV function over time. And so we were able to recruit 22 patients within November 2019 and October 2024. We excluded 4 patients due to extreme prematurity, late diagnosis, significant malformations, and we had to exclude 4 due to the fact that we didn't have 3D echo images available. We ended with 14 patients, which we further separated into 8 patients with liver herniation and 6 patients without liver herniation. These patients were over 34 weeks of gestation with a confirmed diagnosis, and we also excluded anyone who had bilateral CDH, major anomalies, or who required ECMO before we were able to recruit them. So, looking at our clinical characteristics, patients with intrathoracic liver herniation were more likely to have type C or D defects, which are considered more severe. They had longer intubations. We can see that it was 17 days versus 5 days. Longer amount of hospitalization, 70 days versus 11 days, as well as the need for the use of patch during surgery. To note that none of my patients in this population needed ECMO or died. So we use linear mixed effect models to test both the effect of time and the effect of liver herniation on LV performance. This approach helped us understand not only if the heart improved overall after birth, but also whether that improvement was different depending on if you had more severe CDH. So we found that across all infants, ejection fraction, LV mass, stroke volume, apical rotation, twist, and torsion all increased over time, regardless of if you had liver herniation or not. And this was reflecting an expected adaptation postnatally. So this was labeled as echo since we did it at different echo time points. We also looked at the interaction between time and liver herniation, which was significant for end systolic volume, ejection fraction, twist, and torsion. And so the rest of my table is here, and you can see more of my measurements, but I'm going to expand on this with more visual representations. So this means that while all infants showed some recovery, this recovery was altered for those who did have liver herniation. So just to make my point visually, for ejection fraction, we can see that the infants that had liver herniation had a much more blunted rise compared to those without. Now, looking at end systolic volume, what was interesting is that those who did have liver herniation started off with a lower end systolic volume. However, this increased over time, which is suggesting altered LVMTA. Now, looking at my twist and torsion, we would expect a rise that would reflect stronger and more coordinated LV mechanics. However, the liver up group showed a flatter trend, meaning reduced rotational mechanics compared to those without liver herniation. So, overall, these findings suggest that those patients with liver herniation may have persistent alterations in LV performance even after surgical repair. Now, for my strengths, the study used a prospective design with standardized imaging at multiple time points and advanced 4D echocardiography, which is known to be more accurate and reliable than standard echo. All these images were analyzed by a single trained observer, me, which reduced inter-rater variability. I was also blinded to these. And for the limitations, the main limitations are a smaller sample size, which is expected considering that this is a relatively rare disease. Also, this is a single center study that I performed, but it is part of a larger project, which is meant to be multicentric. And we didn't do a longer term follow-up, which is important to understand if these alterations actually are clinically relevant to the impact on their cardiac function. So this is something that we would need to look into. So in conclusion, our study demonstrates that while left ventricular function improves after birth in all infants with congenital diaphragmatic hernias, this adaptation is significantly blunted with those that had intrathoracic liver herniation. However, with larger multi-center studies and longer-term follow-up, this work could ultimately help us better risk stratify our patients, as well as have new interventions for treatments for these infants. Finally, I would like to thank all of my co-authors and the funding agencies, and especially all the support from the NeoCardioLab. Thank you.
Thank you so much, Zoe. Great presentation. So, does anyone have any questions?
I kept the mic. Very, very nice presentation. And again, I apologize for the tough question. I promised my wife I would stop asking tough questions, but here we are. So you have 3 time points, right? But are they at the exact same age, or do they vary?
You mean, does every patient get the actual echo at the same time?
Yeah.
So actually, not necessarily, because, for example, if patients did better, they ended up leaving earlier from the hospital, and so they would necessarily get their echo before they were discharged rather than at the 2-week time point. So that wasn't at that exact point, but using my mixed linear effect model, we were able to use the repeated measurements within those patients and also keep in mind of what time points they had those.
So I was about to ask you what kind of model you could use, but you had just answered my question before I had the chance to.
Great, nice, beautiful as well. He was nice with them. He was nice with you. Good. So, how did you account for pulmonary pressure in this work? You know, it's a big problem in herniated diaphragm hernia.
Sorry, I didn't understand.
Pulmonary pressure. How did you account for that?
So
PA pressure is high,
Hmm.
RV pressure is high, LV function could be impacted upon by the right ventricle volume and pressure. Did you account for that?
we didn't adjust for it necessarily, but these things were being treated regardless of I was looking more at how the heart functions. And so I didn't necessarily account for what the pulmonary pressures were in these. All we looked at was, were they clinically considered to have pulmonary hypertension or not? But I don't think we looked at specifically the pulmonary pressures themselves, more the clinical diagnosis, which is kind of not subjective, but we don't have fully clear guidelines on what is pulmonary hypertension and what is not. And so we only took that into consideration.
You answered. Good. Thank you.
Just say, was it left to right to left, or bidirectional? And can you do a little more of
Yeah. Thanks for the presentation. Currently, bibliography shows left ventricular dysfunction as a strong predictor of mortality. So, are the patients classified would they have prenatal diagnosis or not? Because it's different. It depends of the liver inside the chest, if the patients are with prenatal diagnosis or not.
Mm-hmm. So we did look at if they had prenatal diagnosis or not, but it wasn't significantly different between the two populations. But we did look at if they had a prenatal diagnosis or not.
Okay, thank you.
Yeah.
Okay.
And in our population, about half were outborn that were
Mhm.
So we can use a prenatal marker of severity to stratify the population, knowing that half of the cohort did not have a clean diagnosis. But when you try to stratify by prenatal postnatal diagnosis, there's too limited numbers to actually show the difference. And we know from the literature that postnatal diagnosis
Are more.
There's two fringe. They're either extremely well, and they could be in bone marrow never intubated, and then there's the other extreme that are like the super sick ones that are coming in on 100% oxygen, not sadding, and because they were, potentially no prenatal care from a deep element. So versus the prenatal diagnosis, they're often prepared. Some of them have undergone fetal. So that's another thing. In our cohort, you only have 2 fetal patients. Out of all of these cohorts. So, obviously that also could alter potentially the findings depending if they have prenatal or postnatal.
Okay, thank you very much. Oh, sorry, one more question.
One second.
Fairly simple. The liver herniation, is it binary or 0% blame?
It was either liver up or liver down. Thank you.
Okay, so our next presenter is Dr. Shahada Ali. She's our fellow in neonatology and the next year with us in hemodynamics. Very happy to have her here with us. So she's going to present on the right ventricular function and dimensions by 4D echocardiography in extreme premature infants at 36 weeks. So a little bit combined with what Daniel did.
Yeah.
Okay.
Yeah.
Oh, okay, so you turned it on when you're ready. Ah, thank you. I have to leave it. I'm sorry. You can- Okay, thank you.
Do you hear me?
Thank you, everyone. Thank you, Daniela. So my name is Shahad. I'm a second-year fellow here at McGill. I'll be presenting the study about right ventricular function and dimension by 4D echocardiography in extreme premature infants at 36 weeks, which is a part of the larger study, same as the study for Danielle. So I have no conflict of interest to disclose. So as we know, the myocardium of the extremely premature infants is structurally and functionally distinct and different, and it undergoes a dynamic remodeling process that can influence the both immediate and the long-term and immediate and long-term cardiovascular outcomes. And this unique vulnerability can be also exaggerated by the various postnatal and perinatal exposures, such as steroids or growth restriction. So the data specifically concerning the right ventricle overall is limited compared to in literature compared to the data about the left ventricle. Now there's an emerging echocardiographic technique, which is the speckle tracking echocardiography, which is the 4D echo, that can give us more refined assessment of the ventricular mechanics by quantifying all the subtle myocardial deformation compared to the regular conventional echocardiography. So there's a gap in the literature regarding the comprehensive evaluation of the right ventricular function in these higher risk population. So in our study, we aim to evaluate the right ventricular function at the mark of 36 weeks post-menstrual age, and to see if whether there is an adverse pulmonary phenotypes or distinct RV remodeling patterns. So it's a part of the larger study. It's a single center for my population. They were all from the same center, so it's a single center study with prospective observational method, including infants who were born less than 29 weeks of gestation, who were admitted to the NICU between 2019 and 2023. Where they had for the RV echocardiography and infants with major malformations or genetic syndromes were excluded. So the images were analyzed using TomTech Arena by one blinded reviewer, which is me as, as the rest of the group. Danielle, I think, did my job with explaining how we do the speckle tracking. So it's like a semi-automatically tracking the cardiac borders in the systole and the diastole to give us idea about the volumes and the function of the ventricle. So there was a total population who were screened for eligibility were 451. That was narrowed down to finally to 147 patients. Many patients were excluded either because families denied or patients were died before recruitment or we missed the screening time. So we had total of 66 patients who were on resp support or oxygen at the time of the echo, and 81 patients who were on room air at the time of echo. So in terms of the characteristics and the demographics for the population, so patients were almost like similarly in overall characteristics. Patients with oxygen support were like obviously smaller in gestational age, had a smaller birth weight and had smaller weight at echo time. And also they were small for gestation, and they had lower Apgar score. They had no other differences in terms of characteristics such as the exposure of antenatal steroids or other factors that might contribute to the lung function, such as like chorioamnionitis, for example. So in terms of looking at the respiratory support group, we had 92% of the population who were on CPAP or non-invasive mechanical ventilation or high flow nasal cannula. One patient only was intubated and 4 patients was on low flow. So when comparing the 4D echo parameters, we found that, So first of all, we divided the patients based on the respiratory status at 36 weeks. So this column is for the patients who were on respiratory support, and this column is for the patients who were on room air. So patients who were on respiratory support, they had significantly lower end-diastolic volume and systolic volume, and subsequently stroke volume. Also, they had lower base diameter and mid diameter, so their RV was smaller in size. They also had lower TAPSE, which is one of the indicators for the right ventricular function, and peak longitudinal strain of the septal wall. It was significant also. So after that, we did multiple linear regression to account for potential confounders. So we adjusted for weight at the time of the 4D echo and the exposure to antenatal steroids, and we still found significance in the base diameter of the right ventricle, and they also had a lower functional area. Yes, functional area change, and lower TAPSE and lower PLS of the septal wall and the free wall. So in conclusion, we concluded that extremely preterm infants who are requiring respiratory support at 36 weeks, they show smaller right ventricular volumes, reduced systolic indices, and abnormal right ventricular shape or deformation pattern, which might suggest impaired right ventricular growth and performance. So I wanted to acknowledge Dr. Altit, who is my mentor in the research, and Daniela for helping me always being available. Thank you, and all the NeoCardioLab members and all the co-authors with you. Thank you.
Thank you so much. We have some questions.
Yes, very nice, very good work.
Thank you.
So your groups are without oxygen or mechanical ventilation. The other group is with. Do you think it is because of oxygen and ventilation, or is it because of distress, respiratory distress?
I don't think in our study we can have like a causation. So we don't know, is it because they are having smaller function, that's why they're requiring oxygen, or they have abnormal lung and so their RV couldn't remodel or grow as well as the rest of the body. I'm not sure.
Let me ask you again. Do you think the problem is this respiratory support, or is it the lung disease?
I think it's the lung disease mainly, but we also don't have like
I usually don't ask questions. I ask answers. Okay. So if it was me, I would put these two group of patients without respiratory disease and one with disease, respiratory disease. And despite O2, despite ventilation, they still have some dysfunction or different function of the RV. The way to discern between whether it was the treatment or the disease, which is the O2 ventilation or the disease itself, is to do the same group of patients with and without O2 ventilation, if possible, right? So if the acquisition of the imaging is fast within, let's say, 15 seconds, 30 seconds, then you could potentially afford to stop ventilation on this kid and do your imaging one more time.
Okay.
So this is theoretical. I'm not asking you to do that.
Yeah.
But when you classify your patients, you start with the primal movement of the problem, not the treatment, unless you think the treatment is triggering the differences.
Actually, I don't know. I don't think I have.
Okay.
Thank you.
Thank you. Is there any other question in the room? No. Laila has some question.
Okay, so your study highlight that extremely preterm infant require respiratory support at 36 weeks. Post-menstrual age showed the smaller RV volume and reduced systolic indices. How might these findings help clinicians anticipate or manage cardiorespiratory outcomes, like in this group?
Yeah. Well, I think first of all, to identify these patients early would give us an idea how to follow them, like how frequently we can follow them, or if we need to, like for example, maybe look for any other, like if these patients have also other associated pulmonary hypertension, to try to treat that. I would say maybe it would change the follow-up for these patients more than the management at this point, because we don't have any specific management for the chronic lung disease. So if the patient is requiring oxygen, or if their ventricle is not growing well, at this point we don't have certain treatment or management that we can do, but it might change our follow-up for these kind of patients. Yeah.
Okay, our next presenter is Lina. Lina is presenting on patterns of respiratory pauses, bradycardias, and desaturations in extremely preterm infants in the immediate post-extubation period. Lina is a master student, going to graduate very soon, I think, and she's part of the Smart Hospital team at the NICU. Thank you so much, Lina.
So first, I want to thank you all for the opportunity to present my work today. I have nothing to disclose. So extubation is the transition from mechanical ventilation to non-invasive respiratory support, and it is a critical milestone in extremely preterm infants. However, in this population, the post-extubation period is marked by heightened risk of clinical instability, often in the form of increased cardiorespiratory event frequency and severity, which may lead to an increased risk of reintubation. Despite that, physicians must often make decisions about extubation and reintubation based on clinical judgment, which leads to significant practice variability. Cardiorespiratory events, or CREs, are the most common cause of reintubation in extremely preterm infants. They're defined as a combination of respiratory pauses, desaturations, and bradycardias, and these are frequent and resource intensive in the first month of life. CREs are known to increase costs and prolong NICU hospitalization, and have been associated with increased long-term risk of respiratory and neurodevelopmental impairment. Currently, there are several factors that hinder our understanding of CREs post-extubation. First, the temporal relationship between CREs cannot be determined, as their interpretation and management relies heavily on witnessing, recalling, and charting what happens, and there's no clear threshold of cardiorespiratory event frequency and severity, which can predict the need for reintubation. Understanding these event patterns could help clinicians better tailor extubation management. For instance, if we find that desaturations are frequently preceding pauses or bradycardias, this could indicate rapid lung derecruitment immediately post-extubation, and desaturations could serve as an early marker for instability. Conversely, if we find that respiratory pauses are often leading to the desats or the bradies, this might suggest immature respiratory control, which then could guide interventions to enhance respiratory drive and extubation readiness. And a similar reasoning applies to bradycardia-driven sequences. Thus, we aimed to describe the patterns of CREs in preterm infants during the immediate post-extubation period and to compare the characteristics of these CREs between infants who failed extubation and those who were successfully extubated. This was a secondary retrospective analysis of an unblinded randomized crossover study that enrolled infants birth weight less than 1,250 grams who were electively extubated for the first time from mechanical ventilation to non-invasive respiratory support. Shortly after extubation, ECG, oxygen saturation, and RIP were recorded for 2 hours and analyzed on LabChart and MATLAB. For the first aim, we identified the number of bradycardia events, which was defined as the heart rate less than 100 beats per minute for a minimum of 5 seconds, and desaturation events where the SpO2 was less than 90% for a minimum of 2 seconds, while making sure to exclude events where the SpO2 dropped below 30% as they were likely artifacts. For the respiratory pauses, we used the automated unsupervised respiratory event analysis, or ORIA algorithm, and this was used to identify pauses longer than 3 seconds. The duration and characteristics of these events were then described using summary statistics. To explore the temporal patterns, we extracted each patient's full event sequence from the raw data, ordered the events chronologically, and identified the transitions between consecutive cardiorespiratory events. We counted how often each event occurred, and we computed the probability of moving from one event type to another. Then we measured the time spent in each event before transitioning. We also explored if there is a relationship between the duration of a respiratory pause and the probability of transitioning into a bradycardia or a desaturation. And we looked at the transition patterns at an individual patient level. For the second aim, the number and the duration of cardiorespiratory events were compared between patients that failed extubation and those that were reintubated, and we used the Mann-Whitney U-test. A total of 30 infants were enrolled in the study, of whom 27 had usable recordings. The infants were studied on day 7 of life, had a median gestational age of 26 weeks, and a median birth weight of 770 grams. Of these 27 patients, 10 were reintubated within 7 days. This represented a 37% extubation failure rate. In the data, we identified a total of 2,062 events, and we'll dive deeper into each cardiorespiratory event. There was a total of 1,174 pauses identified in the data, and this histogram shows the frequency and the duration of all the pauses. The median number of pauses per patient during the study was 25, and the median duration was 4.9 seconds. The bar plot on top shows the occurrence of the respiratory pauses per patient, and the box plot on the bottom shows the pause durations per patient. And these illustrate the variability in the number and the duration of respiratory pauses across the individual patients. There was a total of 834 desaturations. The median number of desaturations per patient during the study period was 32, and they had a median duration of 59.7 seconds. Again, the bar plot shows the occurrence of the desaturations, and the box plot on the bottom shows the desaturation durations. And again, there's a ton of variability in the number and the duration of desaturations across the individual patients. There was a total of 54 bradycardias identified in the data. The median number of events per patient was 1 during the study, and there was a median duration of 7 seconds. But again, as shown in the bar and the box plots, there's important variability in bradycardia occurrence and duration across individual patients. To further explore the interrelationships between the events, we looked at the probability and the timing of transitioning from one event to another, and the results are depicted in these matrices. The y-axis shows the starting event, and the x-axis shows the event that it transitioned to. We found that a majority of the events resolved back to baseline. So 96% of respiratory pauses resolved, and this was similar across the bradycardias and desaturations. 82% of desats resolved back to baseline, and 89% of bradycardias resolved back to baseline. Some other notable transitions include 3.4% of pauses that transitioned into desaturations, 16.7% of the desaturations transitioned into respiratory pauses, and 7.4% of bradycardias transitioned into pauses. This heat map displays the transition probability at the individual patient level. So each row represents a patient and each column a specific transition. And as we can see, there's a lot of variability across the patients, which highlights just how heterogeneous the CRE dynamics are across the cohort. We then explored whether the duration of a respiratory pause affects the probability of transitioning into a DSAT or Brady, and we found that the probability did increase with longer pause durations. The probability of a desaturation rose steadily from approximately 4% following a pause of 3 seconds or longer to 24% after a pause 20 seconds or longer. And the probability of a bradycardia increased from 1% following a pause of 3 seconds or longer to 10% after a pause that lasts 25 seconds or longer. For the secondary aim, comparing the characteristics of CREs between those successfully extubated and those who required reintubation, as shown in this box plot, there was no significant differences in the number, which is shown on the left, and the duration, which is shown on the right, between the groups. And this was similar across the desaturations and the bradycardias. They're all statistically similar. But again, since we saw that relationship of probabilities of DSATs and bradycardias increasing, or increasing following a pause that was longer, we wanted to see if there was a difference between the infants that were successfully extubated and those that were reintubated with pauses 10 seconds or longer. And we did see that there was a significant difference in the number of prolonged pauses in those that were reintubated, as you can see on the left. So overall, in the first 2 hours post-extubation, brief cardiorespiratory events are common, but they occur mostly in isolation, and a small percentage of these events are interrelated. We find that the probability of DSATs and bradycardias following respiratory pauses increase with the pause duration, and that reintubated infants have significantly more frequent prolonged respiratory pauses. And these findings suggest that the respiratory pause dynamics may have a predictive value for reintubation risk, but this relationship warrants further investigation in a larger cohort of extremely preterm infants. Some limitations to this study is that the recordings were limited to a 2-hour duration, which may not fully capture the full range of the variability of cardiorespiratory event patterns, and it's hard to determine whether the observed patterns are truly indicative of clinically significant changes or predictive of reintubation that occurs several days post-extubation. So a longer observation period might reveal additional patterns. And we did not assess the impact of CREs on the end organs. And our proposed solution to these limitations is the PEACE project, which aims to use a multimodal continuous monitoring system to capture data from the bedside monitor and NIRS, so to capture the end organ function, immediately post-extubation from 1 hour pre-extubation to 7 days post. Thank you all for your time and consideration, and I want to thank my supervisor, Dr. Shalish, and the PIs of the Smart Hospital Project, and all the members of the Smart Hospital Project.
Thank you, Lina. Good presentation. So because we don't have a lot of time, we only going to take one question.
Hi, thank you very much. Very interesting. We don't have a lot of refined data on that. My question is a little about how can we improve as clinicians? What's your thought about this? Because like what you show is that the duration of the apnea seems to be more relevant, and something like it needs maybe more monitoring. But my thought is, what do you think? I mean, what's the thing that we can already use? Because here we use a lot of paper charts, which adds a bit more subjectivity. But I come from a unit where we have nice graphs where you see every desaturation, bradycardia, simultaneous or not. And I mean, do you think this is already significantly improving our ability to objectively judge children who need reintubation, or do you need there's a very high value to add some more respiratory monitoring and more sophisticated tools that might take a lot of time to come really at the bedside? Do you understand my question?
Yeah. So I don't think, this is my also personal opinion, but I don't think adding any more, like adding a RIP band as a standard of practice, like especially in this population, the extremely preterm infants, there's not a lot of real estate. And I feel like in my experience with the Peace Project, I'm like, I don't want to touch them. I want to leave them be. So I think already what you explained, having more specific data rather than just the charting to see, is this long pause leading to a Brady? Like, I think that would give us more insights, but I think we need to define more what a clinically significant event is, because at least from the data that I see, these infants are having a lot of events, even those that were successfully extubated, but which of these events are clinically significant? Which is the one that's causing the baby to need to be reintubated? I don't know if that answered your question, but
thanks. A lot to learn still.
Thank you.
Thank you, Lina. No much. Okay, so our next presenter and last presenter is Phoenix Plesas Azurdui. She's our PhD student at the NeoCardioLab, and she's going to present on the dexamethasone is associated with ductal closure in extremely preterm infants with evolving lung disease. Thank you so much, Phoenix.
Okay, part of this one is the point. This one.
Okay, perfect. Okay. Hi, everyone. Thanks, Daniela. Yeah, my name is Phoenix. I'm super privileged to be doing my PhD in the NeoCardioLab and looking forward to presenting my results. So as you may know, typical gestation lasts roughly 40 weeks, with babies being born extremely premature, and this leads to immaturity in bodily systems. So the most common complication of extreme preterm birth is bronchopulmonary dysplasia, with 80% of infants born between 22 to 24 weeks being diagnosed with BPD. It's associated with prolonged dependence on respiratory and oxygen support and associated with significant morbidity and mortality. So another common complication of preterm birth is very well described by Dr. Dada, the PDA. It's essentially a vascular structure present in fetal life connecting the systemic and the pulmonary circulation via a connection between the aorta and the pulmonary artery. So as you may know, our systemic circulation is a much higher pressure system after you're born than your pulmonary circulation. So in connecting the two, this results in excess blood flow to the lungs. So when you have BPD, you have this inflammatory response in the lungs that increases this lung water content. You add PDA to it, increase this blood flow to the lungs, and then there's a special vicious cycle of inflammation that just gets worse. So how do we treat BPD? Currently, postnatal corticosteroids are recommended for the treatment of BPD because they're anti-inflammatory and they facilitate weaning from mechanical ventilation. However, they're also associated with adverse effects such as hypertrophic cardiomyopathy, so this thickening of the heart muscle, hyperglycemia, and impaired neurodevelopment. However, the CPS, the Canadian Pediatric Society, recommends that for these babies that remain ventilated for long periods, the benefits of DEXA appear to outweigh the potential adverse effects. So when we give DEXA, we don't fully understand what the effect is on the PDA. So this brings us to our knowledge gap. What are the effects of DEXA on ductal closure? Our aims were to evaluate changes in PDA size and closure rates following DEXA treatment, and our hypothesis was that DEXA would be associated with PDA size reduction and closure. So here's an overview of our protocol. Essentially, extreme preterm infants that were born at less than 29 weeks of gestation were exposed to DEXA, and then they underwent an echo done at each study time point. So that was day 0, day 3, day 7, and day 14 on DEXA, with then 1 and 2 weeks post cessation of DEXA, and then 36 weeks post-menstrual age. So each echo, when we analyzed it, we looked at PDA size and then markers of PDA hemodynamic significance. So as you may know, this is a view of an echo. So an echo allows us to non-invasively take a look at the heart, and here, this red flash here is the PDA. So here is an example of measurement of the PDA size. So here in yellow, we have kind of the PDA measured in its diameter, and right in green, I've highlighted the left pulmonary artery. So you can see it's a 1-to-1 ratio here, which is a pretty significant shunt. However, as nicely highlighted by Dr. Dada, there's a ton of different types of PDA. So yes, the Krushenko classification. So if we just take PDA size as an idea for what's going on at the level of PDA, we don't fully understand what the profile looks like. So we had to take a few other data points. So we looked at velocity of flow through the duct. What does the profile look like? We also looked at the direction of flow post-ductally in the aorta. So all of these markers together, PDA size, profile, velocity, etc., allowed us to kind of ascertain what's going on at the level of PDA. So for our results, there were 277 eligible infants that were born at less than 29 weeks at the MCH NICU between June 2021 and October 2025. We ended up with 53 in our final one in this analysis, with most babies excluded because they weren't exposed to DEXA during their stay. And then here, to give you an idea kind of the babies, their mean gestational age was 24 weeks with birth weight of 759 grams. So really, we're looking at these tiny, tiny babies. So for my first figure, here's the trajectory of PDA profiles across time points. So you can see the line in red is the number of closed PDAs increasing across time points, with the number of restrictive and unrestrictives decreasing as they became closed. We actually had most infants, so 95% with an unrestricted PDA at DEXA start, having complete closure or restrictive pattern at 36 weeks. Here, we're showing you our median PDA size and our open-closed PDA counts across time points. So we have in red our median PDA size, our open and closed counts, and we actually reached a median PDA size of 0 at day 14 on DEXA. The green line there is the median PDA size for the remaining PDAs that stayed open throughout the study. And so our random effects model showed that PDA size decreased significantly over time, and of the 13 ducts that remained open, PDA size decreased from 2.3 millimeters to 1.4 millimeters. So for the final graph, this is our average PDA size reduction in percent across study time points. So we ran a generalized estimating equations model to show that showed a significant increase in the likelihood of PDA closure over time. So we showed that DEXA is associated with a temporal reduction in PDA patency and size. But in the words of Dr. Cavaillé, the PDA is crazy. So what do we do with that? We could consider treating these patients with DEXA before considering treatment, catheter-based treatment, or treatment via surgery, because these are associated with adverse complications as well. So how is DEXA accelerating or potentially accelerating ductal closure? The mechanisms aren't fully elucidated. Here are two that are proposed, is that as Dr. Dada highlighted, prostaglandin maintains the duct open. So it's possible that steroids interfere with prostaglandin biosynthesis or that they reduce the sensitivity of ductal muscle to PGE2. But the bottom line or our hypothesis is that inflammation keeps this duct open. So DEXA, by decreasing this inflammation, allows for ductal closure. So in conclusion, we showed DEXA was associated with a temporal reduction in PDA patency and size, but these are preliminary results, and I plan to continue extracting data until we reach our N equals 60, so 7 more patients. For future directions, it's part of a larger study, so we're also going to be looking at, like I said before, the thickening of the heart muscle, autonomic function, long ultrasound scores. So strengths and limitations, it's prospective in design with blinded cardiac echo evaluators. There's direct clinical relevance and lots of echo time points. The limitations are that for now, the analysis is single center, but as I said, it's a multi-centric study. It's a small sample size for now with no long-term follow-up and no control group for the study. Lastly, like Dr. Dallaire said, your grad school isn't good unless you're having fun. So really, thank you to a lot of the people in this room, specifically Dr. Alte, Daniela, and my fellow students. So thanks so much.
Thank you so much, Phoenix. Are there any questions in the room?
Yeah.
Phoenix, thank you very much. Say my name one more time, I'll give you a mug. Very nice, very interesting. I was triggered by the title of the project. Very interesting. I like the results and so forth. Anytime I see a hypothesis, I ask myself why, at least 4 to 7 levels.